Good evening. My name is Dr. Nick Bilzakevich. They call me Dr. B for obvious reasons. I'm a general surgeon based out of USC, but I've been in practice now for over 8 years and have been here at Hoag for the majority of that time. Again, I'm a general surgeon, but my main focus is in esophageal and stomach surgery with a big emphasis on anti-reflux surgery. I thank you for joining me tonight. I'd like to take the next 40 to 45 minutes or so and really talk to you about what reflux disease is and its progression to esophageal cancer, and then more importantly, what we can do to surgically treat your symptoms and hopefully reduce your risk of cancer. So let's start off by talking about what is reflux disease. Most of you have probably experienced it at some point during your life, if not the last month. Defined, it's just the passage of gastric contents, whether that's acid, bile, digestive enzymes, into the esophagus. As I said, we all experience reflux from time to time, and it is a normal physiologic process with actually some minor health benefits attributed to that. But it really becomes a disease when this passage of stuff into the esophagus becomes troublesome in terms of its symptoms and or develop complications. They can often be debilitating, and if left untreated over many years, can progress to esophageal cancer. So before we dive deep into reflux disease, let's take a look or a little lesson from anatomy. On the left there, you can see a basic diagram of the esophagus, which is a muscular tube that carries food from your mouth, passes down the center of your chest, and crosses naturally through a hole in the diaphragm. And shortly thereafter, it passes into the stomach. Now on the right side, if you take a closer look, there's a sphincter mechanism called the lower esophageal sphincter, or a circular muscle. And we simply refer to this as the valve. And this is what opens to allow food or drink to go into the stomach and should close properly to prevent reflux. So again, a normal sphincter, right, creates a barrier against reflux. It's when a weak or defective sphincter, or when it's incompetent, allows reflux of gastric contents to reflux back into the esophagus. So if there's one point I want you to take away from my talk tonight, it's that GERD is a disorder of the lower esophageal sphincter, or simply called the valve. It is not a disease of too much acid or too strong of an acid. But there's more than just acid in the stomach. As you can see here in the diagram, there's digestive enzymes, bile, pancreatic juice, all of which can have toxic effects on the esophagus. So why is the valve leak? Well, to be sure, we really don't know. But we do know that it weakens over time as the disease progresses. We do know that if someone in your family has it, such as a mother or father, brother or sister, there's a chance you may develop reflux as well. And there's a strong association with hiatal hernias. Now, I could spend an hour talking to you about hiatal hernias, but generally most of you are probably familiar with someone that has a groin hernia or a bulge that goes in and out. It's a very similar concept. It's where that valve is pictured there on the right-hand side of the diagram, bulges up and down into the chest. And if you have a hiatal hernia, you have about a 60 to 80% chance of having reflux disease. The good news is that surgery to fix the hernia also addresses the reflux. So how do you know if you have GERD? Well, if you go to visit any one of your providers who specializes in reflux, you can get up to a slew of tests. The first is the upper endoscopy. It's probably the most important. It allows us to screen for complications of reflux disease before they become symptomatic. Also important is a pH study. Traditionally, this was done with a 24-hour catheter, but now we have 48 to 96-hour pH Bravo technology, which is a wireless test. This is the gold standard in diagnosing reflux disease. It measures how much you reflux. Do you reflux mostly after meals, while lying down, or upright? And very, very important in diagnosing, not only diagnosing reflux, but giving us an idea of the severity of your disease. We also have to get some sort of esophageal motility assessment, and that's either done with esophageal manometry or an upper GI or barium swallow type study, or what we call an esophagram. But often most people come to attention based on their symptoms. Now the most common symptom is heartburn, but it is not always present. All right, I can tell you about 20% of patients with reflux disease never experienced heartburn a day in their life. All right, regurgitation, this is what I call vomiting to the back of the mouth. They bring up that sour or bitter taste back into the back of their mouth. Epigastric pain, this is just upper abdominal pain or discomforts. Again, a bitter or bile taste in the mouth. Chest pain, very, very common. If you look at statistics looking at all ER visits for chest pain, about a third of them are actually related to reflux disease. And this can be so severe, causing esophageal spasm that can even mimic a heart attack. All right, difficulty swallowing, or we call it dysphagia, nausea and vomiting, sore throats, weight loss, right, asthma, right, so that acid can make it all the way up into the back of the mouth and then get down into the lungs and can aggravate people who aggravate their underlying asthma. Likewise, you can get recurrent pneumonias, inflammation of the airways or bronchitis. A chronic dry cough is not uncommon. Dental problems, we see several referrals a year from dentists who notice that the acid reflux is wearing away at the enamel on the patient's teeth. Bad breath, hoarseness and voice changes, often a raspy voice, excessive belching, other problems with gas and bloating, and a lump in the throat. Some people just feel like they have a marble or a little ball caught in the throat. It's what we call a globus sensation, but studies have shown that is attributable to reflux disease. So you can see a laundry list of symptoms, nothing necessarily too specific to reflux disease, so that's why it's important for us to put you through a thorough evaluation to confirm it is reflux before offering you some form of surgery. So is this a serious problem? Well, a lot of people just think I have reflux disease, just kind of like having a hangnail or something, but not quite as serious as depicted here, but it definitely is a serious problem and has its own slew of complications. So shown on the right here is a normal endoscopic picture of the esophagus, showing the kind of whitish pink mucosa with some vessels in the submucosa visible there. This is a picture of esophagitis, so you can contrast with the other picture. This is where that acid that's refluxing up into the esophagus just eats away at the lining of the esophagus. It's essentially a chemical burn. I often tell patients, imagine falling down and scraping your knee and you get an abrasion. Well, this is like an abrasion on the inside of the esophagus and is due to acid reflux. So that's kind of some various forms of esophagitis, but as the disease progresses, you can see here that the lumen of the esophagus starts to narrow as the furrows from the esophagitis start to coalesce. And then here you can see in severe forms of the disease, there's barely any room for the food or drink to go through, causing what we call peptic strictures. So as you would imagine, this is due to scarring of the esophagus, and this leads to, again, dysphagia or difficulty swallowing. Also, we know that with prolonged exposure to reflux, the esophagus, the muscle of the esophagus gets damaged and there's a loss of strength. And this is actually thought to be due to bile reflux as opposed to acid. And as you would imagine, this leads to trouble swallowing. Furthermore, as I alluded to earlier, that acid can make it all its way up from the stomach, get into the back of the mouth, and then enter the airway, passing through the larynx or voice box, affecting the vocal cords, and then through the trachea or windpipe into the lungs. And again, it can very much aggravate people with underlying pulmonary conditions such as COPD, asthma, can lead to recurrent aspiration pneumonias, and in severe cases can cause pulmonary fibrosis, and this is scarring of the lung. And unfortunately, if it gets this severe, the only treatment for this is unfortunately lung transplant. Ear, nose, and throat problems, as I alluded to earlier as well, voice changes, including hoarseness, recurrent ear infections, recurrent sinus infections, and a chronic sore throat. However, the most feared complication of reflux is Barrett's esophagus. Barrett's esophagus is the change in the lining of the esophagus, and we call this intestinal metaplasia. I simply tell my patients it's to consider the lining of the esophagus changes to look more like the lining of the intestine. The intestine is downstream from the stomach, is used to seeing acid and digestive enzymes. It's a protective mechanism, and it's secondary to the chronic exposure of reflux. It's estimated about 15% of patients with long-standing reflux will develop Barrett's esophagus. It is more common in males. And unfortunately, it is a precancerous lesion. Shown here in the picture, as you can see, the whitish pink lining of the esophagus is the normal tissue. And here we see this salmon-colored tissue that tends to grow out of the gastroesophageal junction, or the area of that valve, into the distal esophagus. And we say it has these fingers or tongues or even little islands. And it's, again, this is thought to be due to bile reflux as opposed to acid. And I tell my patients if you have Barrett's esophagus, you have to know one of three things. Either have no dysplasia. Now, dysplasia is a way of thinking of I like to describe it as chaos under the microscope, meaning that when you have no dysplasia, none of the cells are looking like cancer. With low-grade dysplasia, now some of the cells are starting to look a little like cancer cells. And generally high-grade dysplasia, the cells are generally, it's a step before invasive cancer. So even if you have no dysplasia and you have Barrett's esophagus, you have a significantly increased risk of developing adenocarcinoma of the esophagus, up to 40 times the risk of someone without Barrett's. This turns out to about 0.5 to 1% risk per year of developing cancer. Meaning, so if you have Barrett's esophagus for 10 years, you have about a 5 to 10% chance of developing cancer. Now, if you have low-grade dysplasia, as you would imagine, the risk is a little bit higher, about 2% risk per year. Now, if you have high-grade dysplasia, intuitively, again, you would think it's pretty high, or higher than low-grade, but it's significantly higher. Right? I tell you that 40 to 50% have invasive cancer. I base this on studies that were done many years ago where we used to do esophageal resection or esophagectomies for patients with high-grade dysplasia. And at that time, the pathologists, and about 40 to 50% of the surgeries, when they analyzed the specimen, would find a focus of invasive cancer. So there's kind of a myth out there among the general practitioners and maybe some gastroenterologists that, it rarely goes on to cancer. So I told you if you have non-dysplastic Barrett's, again, run-of-the-mill Barrett's esophagus, your chance is about 0.5% per year. I will tell you also that non-dysplastic Barrett's progresses to high-grade dysplasia, again, the step before invasive cancer, at about 0.9% per year. So if you do the advanced math, it's actually about a 1.4% chance of developing cancer per year, either cancer or the step before invasive cancer per year with Barrett's esophagus. So it's kind of like this big elephant in the room, right? We all know that it can progress to cancer, but we're not doing anything to aggressively treat it or necessarily prevent the progression of GERD to Barrett's. So what's our current management of Barrett's? So it's generally if you have Barrett's esophagus, right? The current guidelines, again, non-dysplastic Barrett's esophagus, is to undergo an endoscopy every 3 to 5 years. I can tell you several years ago, the surveillance was every 1 to 3 years, but the new guidelines, because of the very slow progression, are every 3 to 5 years. Now, if you have low-grade dysplasia, as you would imagine, we want to surveillance you a little more frequently, every 6 to 12 months. However, this is falling out of favor for more aggressive treatment with what we call radiofrequency ablation, or RFA, or EMR stands for endoscopic mucosal resection. And these are, I'm not going to spend much time talking about these tonight, but these are endoscopic techniques that are used to ablate and completely eradicate the Barrett's esophagus. Formerly, if you had high-grade dysplasia, again, as you would imagine, we'd see you back every 3 months for an EGD. As you can imagine, patient compliance was an issue. Again, RFA and EMR have a very prominent role here. And as I mentioned earlier, historically we would do esophagectomy, but all the new guidelines written for Barrett's esophagus don't even mention esophagectomy as an option. And unfortunately, for those that present with esophageal cancer, often if they're not a candidate for surgery, if it's too late in the presentation, then all we can do is palliative measures at that point. So what's the risk of watching and waiting? Well, here's shown in this endoscopic picture. Again, you see the healthy mucosa of the esophagus and a background of Barrett's esophagus or the salmon-colored tissue. And you see this large, nearly circumferential tumor. And on the right is the picture of an esophagectomy specimen shown against a scalpel handle for reference. And that's essentially the length of a pencil. So I will tell you this is the biggest procedure that we offer. It is still a very big procedure even though we do it minimally invasive. But the goal, again, is to not get to this point. So where do we stand currently in the United States? It's estimated to be over 19,000 new cases of esophageal cancer diagnosed in the U.S. this year. But unfortunately, that only represents 1% of all new cases. Esophageal cancer ranks 18th on the cancer popularity list here in the United States, so not a lot of attention. And it's currently estimated there's over 50,000 people in the United States living with esophageal cancer. The average age of diagnosis, patients are usually in their late 60s. And Barrett's esophagus is the primary risk factor for esophageal adenocarcinoma. As I'm about to show you, there's been a dramatic rise in the incidence over the past several decades. Now, I will show you this graph here, and you can see that it's dated to 2001, but things have remained pretty constant compared to this graph. But as you can see here in the graph, if you look at the lower lines, these are some of the more common cancers that you're more familiar with: prostate, breast, lung, and colorectal. You can see that the incidences remain relatively stable over the last several decades of the last century. But as you can see in the pink there, the esophageal adenocarcinoma continues to rise, about a 600% increase. And I will tell you, as the more recent data shows, this is leveling off around 670% to 700% increase in the last 2 decades. So what are the risk factors? So again, just having reflux in of itself for greater than 20 years significantly increase your risks. And again, as I already showed you, the development of Barrett's esophagus greatly increases your risk as well. People always think smoking and alcohol lead to a lot of different cancers, and that is true. However, in the esophagus, it leads more to squamous cell carcinoma, which is not as common in our half of the world as opposed to Asia. So I'm going to talk about the progression of GERD and bring you back to this several times. So again, years of chronic exposure can cause Barrett's esophagus, which again progresses to various forms of dysplasia, and over time eventually leads to invasive cancer. And our current mentality is watch and wait. So it is a precancerous lesion, and I do believe that we need to start treating it as such. So let's do a little comparison here. Most of you are probably familiar with the colon polyp, and then if you have a polyp seen on colonoscopy, that it should be removed. So this is a study that came out in 2007 and looked at that year. Over 50,000 people died secondary to colon cancer, and nearly a quarter of that from esophageal cancer. Again, we know the polyp is the precancerous lesion, and trust me when I tell you that the progression is about 0.5% per year. And as you will remember, this is very similar to the Barrett's esophagus, but again, if you combine that with high-grade dysplasia, it's a little bit higher. We know that if you're over the age of 50, and I believe it recently went down to 45, that you should get a colonoscopy to screen for polyps and potentially colon cancer. However, there's no recommendations for screening for esophageal cancer. Surveillance, yes, meaning that if you have a polyp in the colon and it was removed, we ask that you come back more frequently, every 3 to 5 years, for an additional colonoscopy, although this is poor in esophageal cancer. And again, in colon cancer, if you have a polyp, we do our best to take it out. In esophageal cancer, back then at least was watch and wait, but as I said, RFA and EMR have emerged as potential management options. So it doesn't make a difference. All right, so this is a study that came out many years ago, but looked at, does screening colonoscopy for colorectal cancer make a difference? I don't expect you to read the fine print, but they showed that by screening, they were able to dramatically, 77%, lower the risk of colon cancer. So why do we manage these differently? All right, so again, just to summarize, in the colon, we know that the risk of cancer is the polyp, about 0.5% per year. We screen and surveil these patients, and we've impacted colorectal cancer significantly by decreasing 77%. In the esophagus, we have a very similar lesion in Barrett's esophagus. We have no screening and very poor surveillance. And with our watch and wait mentality, the rate of esophageal cancer has significantly increased over the past several decades. So that ends the depressing part of my talk. So let's focus more now on what are the treatment options for reflux disease. So generally, if you see your general practitioner or even a gastroenterologist, you're going to go diet and lifestyle modification. And so we ask you to stop eating and drinking everything that you like to eat or drink in our half of the world. So this means all the spicy foods, right? Any caffeinated beverages, right? Fatty foods. No more In-N-Out burger, all right? So tomato-based products, or for all the Italians, you got to throw out the marinara sauce. Fruits, especially citrus fruits, all right? So no more chocolate, stop drinking alcohol, all right? No more sodas, and avoid large meals, and even certain medications can do that. All of these foods and the medications have byproducts that, when broken down, relax that weakened valve. All right, we also ask you to elevate the head of your bed or sleep with a couple pillows. So I would ask you, how successful do you think this is? Well, the answer is not very. Right? The studies have shown it's about 5% successful. So most of the time, you're going to get started on a medication to control reflux. All right. So the antacids are the drugs originally described. These are the Tums, the Rolates, and the Pepto-Bismols. These are drugs that are great when you're in a social situation and maybe you ate a little too much, and it can help give you instant relief of the reflux. H2 blockers were the original drugs that came out in the 70s. These are the pepsids, the Zantacs, the Axids, and the Tagamates. But most of us will prescribe the proton pump inhibitors that we call the PPIs. Right? These are about 20 times stronger than the H2 blockers. These are the Prilosec, the Nexium, the Protonix, the Esophagus, as well as the Dexilant, which is prescription only. So medications, right, work by reducing the amount of acid in the stomach. Right? So relief is often temporary. Right? They usually work to some degree. But as the disease progresses, if you're taking the medication once a day, you'll soon find yourself necessary to take it twice a day. And it's often necessary that once you're taking it twice a day and it no longer works, that you'll take a different medication. And the pharmaceutical industry thanks you, as this is a huge profit to them. But are patients satisfied with the medical therapy? Right, so this is a multi-center randomized controlled trial, so very good clinical trial. It looked over 5,000 patients. And the whole goal of this trial was to compare Nexium versus Prevacid in its ability to heal esophagitis and to treat heartburn. So if you look at the graph here, I can tell you that Nexium was slightly superior to Prevacid over the days. But as you can see here, depending where you look on the graph, there's about a 30 to 40% gap, meaning 30 to 40% of patients that were not satisfied in terms of symptom relief with their medical therapy. Are PPIs safe? Well, Dr. B, you probably wouldn't have a slide on it if they were. But as you can see here, right, it seems like every area of the body has been affected. Starting almost 8 or 9 years ago, the FDA came out with several warnings showing there was an increased risk of Clostridium difficile diarrhea, what we call C. diff, especially for women, increased risk of osteoporosis, magnesium deficiencies. And again, you can see with each year after the FDA, after the FDA came out with these warnings, there's been an additional body system infected, and even most recently, they've been linked to death from pancreatic cancer. So there's a lot of fear on behalf of the patients to take these medications long term. How about the H2 blockers, right? About 2 years ago, you know that Zantac was recalled due to its concerns for having cancer-causing agents within it. And a lot of the big pharmaceutical and grocery chains pulled these drugs off their shelves. But do the medications stop reflux? Right, this is a study that came out over 10 years ago, but they took 50 patients with documented Barrett's esophagus, and these patients all had pH studies before and after taking proton pump inhibitors. And as you can see here on the graph on the right, on the left is the bar with the patients that were off the medical therapy, and on the right is patients on medical therapy. And you can see they actually reflux the same volume or the same amount, just that while on the proton pump inhibitor, it was much more weakly acidic refluxes. So medications essentially mask the symptoms of GERD. Patients feel better, but the same volume or quantity of stuff comes up. It does not stop GERD. It does nothing to fix that weakened valve. So another myth that's out there is, do these medications prevent the complications that I talked to you about earlier tonight? So in terms of esophagitis, right, we know that the proton pump inhibitors, if taken twice a day for anywhere from 8 to 12 weeks, should heal that esophagitis. All right, strictures, there is data to show that it can, by taking these, it can lessen stricture formation. What about loss of the muscular strength of the esophagus? Well, the data is still mixed on that, especially along with pulmonary problems and ENT problems. It's much like just rolling the dice or flipping a coin. You take your chance and see if it helps you. But there's no data showing that it can prevent Barrett's esophagus or its progression to esophageal cancer. And there's been studies that have looked at that. So this is the big study that came out about 7 years ago now, looking at close to 10,000 patients, I believe out of the Netherlands, that were diagnosed with Barrett's esophagus. Again, all with proven reflux, with complicated by Barrett's esophagus, and they were taking PPIs, and they followed them for out to 10 years. So you can see those patients on the left here that took no medical therapy had a slightly increased risk of developing cancer. But those that took frequent PPIs had over 2 times that risk, and this is 3 or 4 times a week. And those who were taking the purple pill daily, right, had a significantly increased risk of developing esophageal cancer. So the authors of this study show that there was no cancer protective effects from PPIs, and you can read along with me, quote, until future studies can elucidate the association, continuous PPI therapy should be directed at symptom control, and other additional modalities for treatment should be considered. So why is that? You're probably scratching your head. Why are these patients, progressing to cancer? All right. So again, I bring you back to the progression of reflux here for various forms of dysplasia and Barrett's and then cancer. And again, it's thought to be due to bile reflux and not necessarily acid reflux. So you may feel better, but you're still refluxing bile to a certain degree. So let's segue into surgical procedures to treat reflux. The goal of any reflux procedure is to really treat the symptoms and importantly improve your quality of life. So most patients I see in the office, I tell them it's a quality of life issue. You're not going to die from reflux. Yes, it can progress to esophageal cancer, but it's the patient's quality of life that's going to drive the need for an operation. And while we do that, we want to reduce dependence on medication and minimize side effects. So what restores the barrier to reflux? Well, there's generally three main options available to us today. This is the traditional minimally invasive approach, or the laparoscopic fundoplication. There's various forms, but the most common one is called the Nissen. This is what we generally refer to as the stomach wrap. Some newer kids on the block are the magnetic sphincter augmentation, or the LINX device, and then an endoscopic platform called transoral incisionless fundoplication, or TIF. So if we look at minimally invasive surgery, the Nissen fundoplication, right, the Nissen fundoplication as an open procedure was originally described back in 1952 by Dr. Rudolf Nissen out of Germany. It's been being done minimally invasive since 1991. We generally make 5 small incisions, the size of my pinky finger in your upper abdomen. We take the top part of the stomach there as pictured in the diagrams, which is called the fundus, and we wrap it around and suture to itself or plicate it, hence the term fundoplication. The procedure takes 1 to 2 hours. Everyone spends 1 night in the hospital, and most patients are back at work within 1 to 2 weeks. The Nissen is very, very effective in controlling reflux, right? It's very effective in stopping all reflux, right? Acid, bile, pancreatic enzymes, etc. Patients are generally able to stop all of their medical therapy immediately following the procedure, and studies have shown it decreases the chance of developing Barrett's and the progression to esophageal cancer. But unfortunately, there are some side effects to the fundoplication, and if you were to Google any of this, you would find it's all over the web due to social media. But there is a difference. This is an advanced minimally invasive procedure, and studies have shown that if you have your procedure done at a high volume center like here at Hoag, very, very high success rate. Although if you have your procedure done at a community hospital where they may only do 5 to 6, maybe a little bit more Nissen fundoplications per year, the success is not as good. And there are some side effects, right? So the vast majority of patients after a fundoplication have the inability to belch or vomit. To most people, that's not a big deal, but we all swallow air when we talk and when we eat, and if you can't belch, gas and bloating can be problematic. I will tell you that gas and bloating is usually temporary, usually lasts about 3 to 4 months, and is very well controlled with diet modification and then some Gas X or Beano over the counter. And generally, because of the edema or swelling in the esophagus from the surgery, everyone has trouble swallowing in the short term for the first couple of weeks following the procedure. As a result of that, we usually have on a very slow diet advancement, meaning you leave the hospital on clear liquids, and within thicker days you're on thinner liquids and thicker liquids after a couple of days, so smoothies and whatnot. By 2 weeks, most people are tolerating softer foods, and then by 4 to 6 weeks, people are generally eating fairly regular. So that's it for the Nissen. So let's talk about the LINX. So as pictured there in the video, right, this is a bracelet of titanium beads. Inside each titanium bead is a rare earth magnet. Rare earth magnets designed to never wear out. And the strength of each magnet is calibrated precisely to restore the natural function of that weakened valve and yet preserve normal physiologic function. And it is a metallic implant, and the current device is compatible with most MRIs. Those up to 1.5 Tesla in terms of the strength of the magnet. And you can see there it's been out now for over 9 years. So the main thing with LINX, again, is it allows normal physiologic function. And you can see it's placed around the lower esophageal sphincter as pictured here. The LINX itself from the magnets produces a barrier of about 20 millimeters of mercury of resistance. I will tell you that normal esophageal pressures generate significantly above that, 35 to 80. So meaning that when you swallow, as pictured on the right, your esophagus can generate enough force to force the food or drink to overcome the resistance of those magnets and to go into the stomach. However, I will tell you that normal intragastric pressure, as pictured there on the bottom, is about 5 to 10 millimeters of mercury. So in its resting state, the magnets provide enough resistance to be a barrier to reflux. But if you need to belch or vomit, i.e. increase your intragastric pressure, you're able to do that and overcome the resistance. And that's the main difference in comparing LINX to traditional fundoplication. So like the Nissen, it's minimally invasive, although it takes a little bit less time. We're not wrapping anything or plicating, so there's no alteration of normal anatomy. Most patients go home the same day, as opposed to the Nissen, once they get back to a normal diet as quickly as possible. The main difference is it allows patients to belch and vomit, and therefore significantly eliminates or significantly decreases that gas and bloating associated with the fundoplication, and it can be removed if need be. So here's a picture. This is showing a patient who I operated on. This is an endoscopic view of the valve. The patient had a hiatal hernia which has been fixed. The LINX is actually in place, just has not been classed, so the bracelet has not been formed. And here's a picture showing that. So I like to show this to my patients because they look at this picture and they kind of make sense that the picture on the left is associated with ongoing reflux, and you can see a nice, nicely reconstructed or augmented valve there on the right. So let's look at some data. So again, this is looking at a pH study. And so we look at a couple different trials here. The first trial is the FDA pilot trial, which looked at 44 patients over 4 different centers and followed them for 4 years. And you can see anything above that dotted blue line that's going across is considered pathologic amounts of reflux in the distal esophagus. After implantation, greatly reduced amounts of reflux. The pivotal trial looked at 100 patients, and this was published in the New England Journal of Medicine, the next big study to look at LINX after it came out. Again, significant improvement in esophageal acid exposure afterwards. And then this one study out of Italy at one center, again showing. So this basically showing that the LINX device works in controlling exposure of the distal esophagus to acid. So what about quality of life? So some of you may be familiar with the GERD-HRQL, which is a symptom-based questionnaire we use to really assess the severity of your heartburn and associated symptoms. And that will tell you severe scores with scores greater than 20 or 25. Here we'll throw in a 4th study out of Europe. We can see in these studies all these patients had significant amounts of or greatly impacted quality of life prior to implantation, and greatly reduced scores showing a significant impact on quality of life after implantation. What about medical therapy? So as you would imagine, if you're designing a trial, you want 100% of your patients taking PPIs prior to implantation. And here we are after implantation, showing greatly improved or great independence from medical therapy. And then again here, if you look at the top 2 graphs, you can see the vast majority of patients after implantation, 96 and 97% of patients maintain that ability to belch or vomit if needed, and therefore great reduction in the ability of gas and bloating sustained out to 4 years. So the durability of LINX, it's been around for a while. I will tell you, initially when the LINX device came out, there was a lot of hesitancy from insurance companies to approve the procedure. But now that it's been out for almost 9 years, we do have some data showing long-term durability of the LINX device. And again, this is everyone talks about data out to 5 years. So here you can see this is a chart looking at significantly increased amounts of heartburn, regurgitation, dependence on medication initially, and greatly reduced amounts and sustained out to 5 years. Again, here looking at the quality of life survey without medical therapy and with medical therapy in the middle, and then after the LINX device was placed, greatly improved quality of life sustained out to 5 years. Looking at freedom from medical therapy, so you can see at baseline 100% of patients were taking either once or twice daily PPIs. At 5 years, close to 80%, over 80% of patients taking no medical therapy or just as needed. Some other symptoms the trials weren't generally designed to look at, but you can see ranging from gas, bloat, and diarrhea to constipation, along with nausea and vomiting, all improved in the studies. So this has been shown across multiple studies. As you can see here, the follow-up in these studies ranges anywhere from 6 months out to 5 years, again showing quality of life scores indicating severe impacted quality of life from 20 as close to 30, down to the single digits at their follow-up. Looking at use of medical therapy, again, anywhere from 6 months to 5 years, greatly reduced dependence on medications following implantation. And in these few studies here looked at regurgitation. Again, that's that stuff coming up into the back of your mouth with a bitter or sour taste, greatly reduced amounts of regurgitation. So I think it importantly expands our options in treating that barrier defect associated with reflux disease. I think the Nissen on one hand is really used to reconstruct a valve that's totally been destroyed, where this LINX device allows us to really augment the natural function that's left. It's reproducible, it's minimally invasive. Again, we're not distorting any anatomy. And most importantly, it allows us normal physiologic reflux and there's functions of belching and vomiting. And it doesn't limit any additional treatment options. So let's talk about endoscopic options. So I put this GERD graveyard out there because in the mid-2000s there was a lot of hype and excitement about incisionless surgery, right, or scarless surgery. And so a lot of endoscopic platforms were designed to try to do anti-reflux via endoscopy. As you can see, the Enterix was a device here that injected a polymer into the LES to help bulk it up. The Gatekeeper actually implanted these little plastic polymers in there. They even looked at placing plexiglass, of all things, into the lower esophageal sphincter. The EndoCinch was a suturing device to help bulk up that valve. And likewise, Applicator was a similar suturing device. So unfortunately, all of these have come and gone by the wayside as their long-term durability was not proven, or there were some safety concerns. But in that same era, with the TIF came about, and it's the only device that's kind of maintained its popularity since then. And the whole point of this is to perform a fundoplication endoscopically. It creates a valve 2 to 4 centimeters in length, which is essentially the length of a surgical fundoplication. Unlike a Nissen, which is 360 degrees, this is a partial fundoplication, or 270 degrees. There's been several modifications made since its initial FDA approval. We're currently on the TIF 2.0 technique, and the device is called Esophagus. I'm going to show you a video here. This is the actual Esophagus device. As you can see, it looks very much like an endoscope with a reticulating head that can retroflex. So here you can see this endoscope is actually passed through the device. This procedure is done under general anesthesia, and it's an endoscopy that comes down. And so we use the endoscope to visualize the procedure. And through the platform, we're going to deploy a device called a helical retractor, which is going to grab that area of the valve. And then we retract it and pull it back down into the stomach. And then here you're going to show a picture of the H fasteners being fired, right, that plicates or hold that valve in place. Now we do this multiple times, 15, 20 or more fasteners. And here you can see it creates a nice 2 to 4 centimeter valve that becomes a nice barrier for reflux. So again, it's performed under general anesthesia, but it takes less than an hour. And the advantages are it's scarless, it's incisionless, so it's less invasive. Patients generally go home the same day or occasionally stay overnight. Patients generally have very little to no pain following the procedure. They recover pretty quickly, and there's fewer side effects with this procedure than associated with the traditional fundoplication. Let's look at some data. This is the RESPECT trial where they randomized patients to TIF versus a placebo. And the main emphasis on this trial was they screened patients for that troublesome regurgitation. So they had 87 patients who underwent the TIF procedure, and then 42 patients had a sham procedure, which means they pretty much went to the OR and just had an endoscopy, and they were treated with 6 months of PPI, but thought they actually had the TIF procedure. But the patients were blinded to wood therapy, and then failures at 3 months were unblinded and crossed over, meaning the patients who had the sham procedure, if they weren't well controlled, could cross over and get the TIF procedure. At 6-month follow-up, you can see here that the resolution of that regurgitation was seen in over 2/3 of patients in the TIF group, so showing some good efficacy in controlling regurgitation. The TEMPO trial was the next big trial in a similar fashion that looked at the results of TIF. 63 patients, as you can see, 2/3 had TIF, and another third were just treated with medical therapy. At 6 months, all patients in the medical therapy group crossed over and got TIF. And again, this study was looking at daily regurgitation. At a 3-year follow-up, you can see that 90%, so the vast majority of patients were free of regurgitation. Again, just as many were free of atypical symptoms, and close to 3/4 were free of daily proton pump inhibitor therapy. Again, showing quality of life greatly impacted pre-TIF and then sustained out to 3 years. These authors then went on to publish their data at 5 years. Again, you can see greatly sustained relief in the high 80s in terms of relief from regurgitation, and still greatly improved or great independence from PPIs sustained out to 5 years. And again, quality of life greatly sustained out to 5 years. So in conclusion with TIF, I think it's a good option. It's a good tool for us to have in our toolbox that can reduce GERD in select groups of patients. It is an incisionless option, so this is an attractive alternative for those patients who don't have a significant hiatal hernia, which would otherwise require surgical repair. It has a low incidence of side effects, especially compared to the traditional surgery. Data is emerging to solidify this. There's no way this is headed for the graveyard per se. And the device has been modified and simplified, which makes it a much more straightforward and reproducible procedure. So as I kind of wind down here, I really, I talk to my patients and I say, you really got to look at the disease of the lower esophageal sphincters on a continuum. So I still think medical therapy has a role. So as that valve is starting to fail, there's still a lot of good function left in it. Medications do have a role, and the risks of surgery outweigh potentially any benefit. But as the disease progresses and that valve continues to fail, I think we have some good intermediate options, whether it's TIF or LINX device, to help kind of augment or treat whatever natural function is left. And yet I still think the Nissen or any fundoplication is a good option. So when that valve is completely shot, that it just really needs to be reconstructed, the fundoplication is a very, very good and still viable option. So in summary, I hope I've shown you that GERD is a actual serious medical condition. Right? It's much more than just simple heartburn, and if left untreated, can lead to complications including esophagitis, strictures, Barrett's esophagus, and potentially esophageal cancer if left untreated. Medications treat the symptoms, right, but not the underlying problem. They do nothing to fix that valve or weaken sphincter. I showed you that medications do not reduce your risk of developing Barrett's esophagus or cancer. Yes, you may feel better, but the disease can still progress. So my final proposal to you is stop the progression. Many of you have stared at this section of the supermarket for probably too long. Studies have shown that grocery stores develop more space to these products than any other product in the store. So I bring you back to the progression of GERD. So over time, if left untreated, progresses to Barrett's and various forms of dysplasia and to eventually cancer. We have this kind of watch and wait mentality. So I urge you to help us do something about it. Let's stop the progression. Again, my take-home point, it's a disorder of the sphincter. It's not a disorder of too much acid. A normal sphincter creates a barrier against reflux. A weak valve allows that reflux. So we need to do something to fix the valve. The problem is the valve. So I urge you to come see us, do something to fix the valve, whether it's with the traditional fundoplication or our newer therapies such as TIF or magnetic sphincter augmentation with LINX. I thank you for your time, and I'm happy to take any questions. All right, so I do have a couple questions that came in from the audience, and I thank you for participating. The first question is, what about an esophageal diverticulum? I could spend probably 30 minutes talking to all of you about esophageal diverticulums, but there's generally 3 different areas in the esophagus where they can occur. Proximally in the neck is what we call a Zenker's diverticulum. There's mid-esophageal diverticulums, and then there's what we call epiphrenic diverticulums, which occur generally just above the diaphragm and above that weakened valve. Reflux has nothing to do with diverticulums. Diverticulums are generally due to an underlying motility disorder of the esophagus. They can trap food and occasionally cause bad breath and obviously trouble swallowing. But if you do have one, it's a very similar workup to what we do for reflux disease. And we do have surgical treatments where we can generally treat the underlying obstruction. Now, I did mention to you that reflux disease is where that valve usually opens fine but doesn't close properly. Some of the diverticulums are closed by where that sphincter doesn't open properly. So it requires a lot more strength of the esophagus to open. You can imagine if the esophagus is pushing and pushing and squeezing harder to open a valve that's harder to open, that there's areas of the esophagus that kind of bulge out and become a weakness or a diverticulum. And just as there's a sphincter at the lower portion of the esophagus, there's another sphincter at the upper portion of the esophagus called the upper esophageal sphincter, which is responsible for the Zankers. So if you have one, definitely come see us. We can definitely treat it for you. I guess some follow-up questions. Could that become Barrett's? Again, no. There's no relation from reflux disease and causing esophageal diverticulums. And what's the greatest risk? Well, I think the greatest risk is that these diverticulums can trap food, and sometimes they can make it back up into the airways and cause a risk for pneumonias, which can be a threat to especially our elderly patients. So they sometimes can get pretty big where they can compress other structures, but that's more rare. Our next question is it accurate to say that PPI and other medications can reduce the symptoms of reflux but do not reduce the chances of developing cancer? Absolutely. All right, so again, PPIs definitely can treat the symptoms of reflux. Patients generally will feel better, and we know that if patients respond to medical therapy, that's usually a predictor of success for anti-reflux surgery. But as I showed you in the one study, and there are many other studies that I did not show you tonight, but PPIs do nothing to reduce the chances of developing esophageal cancer. And again, the medications do nothing to reduce the amount or volume of stuff coming up into the esophagus. So even though you feel better, the esophagus is still being exposed to those toxic effects, and over years can lead to Barrett's and esophageal cancer. I appreciate the questions, so keep coming in. So do these 3 procedures reduce the risk of Barrett's esophagus? Very, very good question. So I can at least speak to data for the traditional fundoplication. And generally we know that many studies suggest that by controlling the reflux, the Barrett's doesn't get any worse, meaning it doesn't progress. There are several good studies showing that with control of the reflux with a fundoplication, that Barrett's actually regresses or goes away. I can tell you that as we are a leading center in the country for magnetic sphincter augmentation with LINX, we have looked at this in terms of our Barrett's esophagus. We have shown that by controlling reflux with LINX at 1 year of follow-up, we had none of our patients progressed, very similar to the fundoplication. We actually had a 79% regression rate at 1 year, meaning we generally bring our patients back for an endoscopy at 1 year following LINX. 79% of them had no evidence of Barrett's esophagus seen on multiple biopsies. So we're really encouraged by that, and we'll hopefully have more long-term data as the time approaches. TIF is, like LINX, is a very similar procedure. I'm not aware of any studies looking specifically at Barrett's and transoral incisions of fundoplication. However, I would feel that it would be as similar as by doing anything to control the reflux should reduce the chances of progression and even maybe induce regression. In a very similar vein, the next question is, can Barrett's reverse after the surgical procedure to fix the valve, or does it just not progress? So hopefully I just answered that with the last question, but again, with Barrett's, controlling the reflux, the disease generally shouldn't progress and can even regress. And I tell my patients, when they come to see me, you have Barrett's esophagus and you have reflux disease, right? Barrett's in of itself is asymptomatic. So we don't operate to treat the Barrett's. So meaning if we have an asymptomatic patient with Barrett's esophagus, we don't necessarily operate to reduce the chance of the Barrett's progressing or reduce the chance of developing esophageal cancer. We operate on the symptoms of reflux disease. Often they very much go hand in hand. But as I mentioned, we do have newer therapies such as radiofrequency ablation or endoscopic mucosal resection, and that's usually reserved for nodular Barrett's, so that it just kind of carves out the Barrett's endoscopically. We have those therapies that we can use to treat Barrett's in of itself. Keep them coming. Must we have an endoscopy prior to contacting Hoag Cancer Center? Is any of this covered by Medicare? With the latter, a lot of it is covered by Medicare. Some of the newer procedures such as LINX and or TIF may have some more difficulty with Medicare. Must we have an endoscopy? Absolutely no. I am one of 4 surgeons in our group. A lot of us prefer to do our own endoscopy. But if you work closely with a gastroenterologist and are due for an endoscopy for whatever reason, just mention that you're considering having surgery and then request that a pH study would be done. It's one thing if you have complications of reflux on endoscopy, that kind of seals the deal in terms of guaranteeing the diagnosis, but unfortunately a lot of insurance companies still want to see the pH data. So what we see most commonly is patients are referred to us and they've just had an endoscopy several weeks ago, but no pH study was done, and that would often prompt us to repeat the endoscopy. So you don't necessarily need to have it, and a lot of our gastroenterologists here at Hoag, since we've been here for over a decade now, generally know that we like to do our workups, and we'll just send you right over. And then another question regarding the 2 recommended procedures: what if the patient has no symptoms of reflux? So again, if a patient's asymptomatic, the risks of surgery outweigh any benefit, right? It's hard for me to take someone who's not on medical therapy and may have had heartburn from time to time to really put them through an operation that, every operation has its potential risk for complications and or side effects. So if there's no symptoms, and again, they may even have Barrett's, we generally will surveil those patients and follow them over time. Now, I will tell you, if you do have a hiatal hernia, which a lot of patients see that or a lot of patients have a hiatal hernia that we see in the office, they're not going to fix themselves, and they will get bigger with time, and patients will generally develop symptoms as time goes on. The next question is, I've been taking famotidine or Pepsid and other drugs for years. How often should I be checked for progression of deterioration and taking further action? Well, again, as I noted in the talk, there's no good guidelines for surveillance endoscopy in patients with reflux. Often patients will go to see their family practitioner or the gastroenterologist. They'll be started on a medical therapy. They'll reassess their symptoms in 2 to 3 months, and kind of if you're feeling better, well then here, take this medication for life, we'll see you in a year or so. So it's not only if you have any warning signs such as dysphagia or if you see or any complications or noted on endoscopy that you would be referred for surgery. So unless you have a family history of Barrett's esophagus, a family history of esophageal cancer, I can tell you if you're male or over the age of 55, if you may be obese, these are some things to consider that put you at a slightly higher risk of developing Barrett's and esophageal cancer. But often there's no good guidelines, as I noted. There's some guidelines that say that if you're over the age of 55 and you have reflux disease and you have one endoscopy and it looks fine, there's no concerns, that you don't need another endoscopy the rest of your life. So again, no good guidelines. So again, if you're concerned, and I think at the point where your symptoms are progressing on medical therapy, again, where you develop warning symptoms such as dysphagia, then you should definitely be further evaluated. Post-procedure, what would improved symptoms imply? So generally, we're looking for resolution or elimination of heartburn and any of the preoperative symptoms. Again, I showed you that laundry list of 20 different things that can be attributed to reflux. We want to see that there's significant resolution in those and a great improvement in the quality of life. In this vein, I will tell you the LINX device, it doesn't eliminate heartburn. Like a good fundoplication will really eliminate heartburn. But again, the LINX device allows normal physiology, and so that if you overeat on the holidays, you may still experience a little bit of heartburn. It takes someone with abnormally high levels of reflux and brings it back down to normal levels of reflux. The next question is TIF used for hiatal hernia. So the current FDA guidelines for the TIF procedure generally recommend TIF is a eligible procedure if you have a 2 centimeter or smaller hiatal hernia. That means by definition, by performing the TIF procedure itself, we're able to fix or reduce a 2 centimeter hiatal hernia. Anything bigger than that, so a 3 centimeter or bigger hiatal hernia, generally requires surgical correction. Now, kind of a hot area of interest right now is surgical repair of the transoral incisionless, surgical repair of the hiatal hernia followed by a transoral incisionless fundoplication, or we simply call a CTIF, or a combined or concomitant hiatal hernia repair and TIF. This has been an area of growing interest over the past couple of years, and there are some data to emerging that this is potentially a viable alternative. So meaning that even if you have a larger hiatal hernia and you're still interested in the TIF procedure, you could have both. Next question is, can controlling the symptoms with medications reduce the incidence of asthma attacks? I'm not sure of any data that shows that controlling the reflux with PPIs can reduce the severity of asthma or the incidence of asthma attacks. I would say my recollection is that patients with asthma who have or well-controlled heartburn and whatnot by PPIs do have less frequent asthma attacks. I'm not so sure about the severity, but I can definitely tell you that I have asthmatic patients who have had anti-reflux surgery, whether it's fundoplication or the LINX device, and they're essentially able to throw their rescue inhalers away, that their asthma was essentially driven by reflux disease. The next question is, are P&D, which is postnasal drip, sneezing, and a runny nose only in the morning a symptom of reflux? It very well possibly could be. This kind of brings me to a more broader topic that, the first thing that comes to mind is allergies. But as I showed you in that list, and especially the slide showing the potential pulmonary and ear, nose, and throat complications, that obviously there are other things that can cause cough and pneumonia and sinusitis and chronic sore throat. So we work very closely with our pulmonologists as well as our ear, nose, and throat physicians here at Hoag. And often patients, before they come to me, have already been evaluated. They may just have a cough and they see a pulmonologist and they get a thorough evaluation, bronchoscopy, CT scan of the chest, or an ear, nose, and throat physician who says, who sees changes of reflux on the vocal cords, and then they come to me. So likewise, if I see a patient who I suspect has some more atypical symptoms of reflux such as these, it may prompt a workup, and the pH study will be negative, and the endoscopy will be rather unremarkable. And that'll prompt me to have that patient be evaluated by our ear, nose, and throat or pulmonary physician. So we work very much close in hand. So this possibly could be a symptom of reflux. In the morning, generally patients who reflux, their symptoms are worse at night. As they lie down, that valve is kind of open and things can just flow either evenly across, and can potentially exacerbate symptoms potentially in the morning. So it's definitely a possibility, but can't say for sure without further evaluation. So currently, the next question is TIF or LINX covered by Medicare? So TIF currently is not. TIF is currently covered by Medicare. The LINX, a straightforward LINX procedure generally is not. But if it's associated with a sizable hiatal hernia, then it can definitely be a viable option. Well, again, it seems like there are no more questions, but I'm sure many of you have questions out there. So again, I thank you all for your time. And if you do have any more questions, please call the office or come see us in person. We're at the Hoag Cancer Center, just behind the hospital here at Hoag in Newport Beach. And again, I thank you for your time, and good night.